Over 300,000 women each year carry a child to term. In 2021, 67% of maternal deaths in Australia are directly related to complications in pregnancy, with most of these occurring during the first trimester, on the day of delivery, or within 7 to 14 days after childbirth. As a first responder attending to an obstetric emergency, there are a number of things to consider impacting the way we examine, assess, and treat a patient in a pre-hospital setting. To accommodate the incubation of fetal development and growth, a female's body adapts and evolves to enable the incrementally increasing metabolic demands of a developing baby. The term embryo and fetus refer to different stages of prenatal development in the first trimester, each with distinct characteristics and developmental milestones. Major milestones in the embryonic period up to the 8th week of development sees the foundational structures for life forming. The embryo begins to develop a heartbeat, spinal cord, and early limbs with a more rudimentary and less human-like appearance. The transition from embryo to fetus in week 9 of gestation marks a shift from the initial formation of basic structures to the growth and refinement of those structures into a more recognizable and functional form. By the end of the first trimester, the fetus is around 5.4 centimeters in length, measuring from head to tail, and weighs about 28 grams. In the second trimester, facial features become more distinct. The gestational interval marks the full maturity of all fetal body systems, movement, reflexes, and skin changes as the fetus prepares for delivery and life in the outside world. There are 3 stages of labour. Delivery of the fetus occurs in the second stage of labour, followed by the placental structure in the third stage. In stage 1, the uterus will contract, directing the fetus towards the birth canal. At the same time, the cervical opening will dilate to 2 centimeters to allow the ejection of the newborn safely. When the cervix is dilated at 6 centimeters, a woman is considered to be in active labour. Stage 3 occurs after delivery of the infant and ends after delivery of the placenta. Placental delivery usually occurs within 9 minutes of infant delivery on average.
Any disease or condition that affects the health of either the mother or baby constitutes what is known as a pregnancy complication. This can include hyperemesis gravidarum, which is a severe form of nausea and vomiting that occurs during pregnancy. It goes beyond the typical morning sickness and can significantly impact a person's health and daily life. Symptoms can include persistent nausea and vomiting that may lead to dehydration, weight loss, and electrolyte imbalances.
Gestational hypertension is high blood pressure that develops during pregnancy. It typically occurs after the 20th week of gestation and can be classified into several categories.
Gestational hypertension is standard high blood pressure that develops during pregnancy to meet the demands of metabolic needs of mother and baby, which later resolves itself post-delivery.
Preeclampsia is characterized as high blood pressure with the presence of a protein in the urine. This protein can affect other organs and complications leading to full organ system failures.
Chronic hypertension is high blood pressure that existed prior to pregnancy or was diagnosed before the 20th week of gestation. If someone, for example, with chronic hypertension develops gestational hypertension or preeclampsia, it is often referred to as a chronic hypertension with superimposed preeclampsia.
Gestational hypertension can increase the risk of complications for both the mother and the baby, such as preterm birth, low birth weight, and the placental obstruction.
Treatment strategies for the paramedic out on the field typically involves regular monitoring of blood pressure, lifestyle modifications, and sometimes medications to control blood pressure and reduce the risk of complications. In some cases, early delivery may be recommended to protect the health of both the mother and baby, and by maintaining stability, both patients can be immediately transported to the specialized care facility needed.
Gestational diabetes is a type of diabetes that develops during pregnancy in women who have no prior diabetic history, and it resolves after childbirth. This condition develops as a result of the baby's placenta producing hormones that can make cells more resistant to insulin.
The pancreas is then unable to produce enough insulin to overcome this resistance. It will present with thirst, frequent urination, fatigue, and blurred vision.
Major complications for the baby can include a premature birth, macrosomia, respiratory distress syndrome, and for the mother, the major complication is preeclampsia.
In a pre-hospital setting, the paramedic monitors BGL status, considering applicable contraindications and adverse effects for pregnancy in pharmacological intervention to assist return to normal baseline.
A large proportion of pre-hospital emergencies we will attend to will be complications occurring during childbirth. A number of life-threatening events, both to mother and baby, can occur when the fetus exits the mother's uterus in a way that causes harm to one or both lives.
We all know that in general terms, a breech birth is one where the baby enters the delivery phase feet first instead of head first. This can occur because of the lack or excess volume of amniotic fluid that restricts or overexcites movement of the fetus in utero, limiting the chances of the baby naturally positioning correctly.
When the baby's arm is stuck and preventing it from being delivered, the first responder can sweep down the arm by placing fingers or a hand inside the birth canal and sweep this.
By lifting the buttock where it presents through the birth canal, we can assist the delivery of the shoulders. This works by redirecting the pressure and path the baby is in to allow it to slide through the birth canal with less resistance.
Rotational techniques during the birthing process assist in positioning the baby in a way that ensures minimal risk of trauma and further complications.
The modified Morisot procedure entails suprapubic pressure by one obstetrician on the mother's uterus, while another obstetrician inserts their left hand in the vaginal passage, palpating the fetal maxilla using the index and middle finger, gently pressing on the maxilla, bringing the neck to a moderate flexion. The left hand's palm should rest against the fetus chest, while the right hand can grab either the shoulder of the fetus and pull it in the direction of the fetus's pelvis. The combined neck flexion, traction on the fetus towards the hip pelvis, and the suprapubic pressure on the mother uterus allows for delivery of the head.
Prolapse chords occur when the umbilical cord collapses or bulges anywhere along the birth canal, interrupting the pathway of the fetus's exit. The compression of the umbilical cord can restrict blood flow and oxygenation, putting the life of the baby at risk.
Postpartum hemorrhage is when a woman experiences an excessive amount of bleeding following delivery. Primary postpartum hemorrhage occurs in the first 24 hours, in which blood loss volumes of between 500 ml per litre are lost due to complications.
Secondary postpartum hemorrhage occurs more than 24 hours post-delivery, with blood loss experienced below 500 mL and can continue for up to 3 months.
Signs of postpartum hemorrhage include persistent excessive vaginal bleeding, hypertension, tachycardia, pale and clammy skin. Bleeding complications of pregnancy can be life-threatening, are time-critical, and require immediate attention. Minimizing bleeding and managing vitals is the treatment rationale in a pre-hospital setting, as specialized surgical intervention and medical care is needed.
Pregnancy-related trauma involves high-force blunt events to the abdomen. These can result from minor falls, bumps, piercing, blunt force object strikes, and motor vehicle accidents, for example. Minor trauma in the first or second trimester increases the likelihood of triggering a premature labor or underweight child. Depending on the level of severity, complications from traumatic injury can trigger other bleeding complications, ruptures, abruptions, delivery, or compromise fetal development and death of the mother.
A spontaneous termination is what is commonly referred to in layman terms as a miscarriage. It usually occurs in gestation before 20 weeks, and it can result from infections, hormone imbalances, chromosomal abnormalities, and illnesses affecting the mother, compromising the viability of fetal development, enabling them to carry to term. It will present with tissue passing, cramps, and vaginal bleeding.
Fertilized eggs that fail to adhere to the uterine lining and develop outside of the uterus's main cavity are called ectopic pregnancies. The most common location for an ectopic pregnancy is in the fallopian tube, known as a tubal pregnancy. Eggs can also incorrectly implant themselves in the ovary, the abdominal cavity, or the section of the uterus that attaches to the vagina or cervix. Viability and successful fetal development is not possible outside of the uterus. It will often occur in patients with a history of ectopic pregnancies, fallopian tube surgeries, from infections, and in some cases due to fertility therapies. On presentation, paramedics check for vaginal bleeding, investigate PQRST, sharp or stabbing pain, and look for symptoms of shock which can indicate possible rupture.
Placental abruption can be full and partial tears of the fetus's nourishment structure from the uterine wall, causing internal or external bleeding. As the mother hemorrhages, the fetus's oxygen and nutrient supply declines, putting both lives at severe risk. High blood pressure, recent trauma, substance addiction, and lifestyle factors should be investigated in our ample if suspecting this type of bleeding complication. It will present with contractions, uterine soreness, abdominal pain, and vaginal bleeding.
Placenta previa is when the placenta develops in a position that partially or fully obstructs the cervical opening. This makes a vaginal delivery unsafe and impossible, requiring cesarean delivery. Causes in our ample and history taking should consider smoking, multiple gestations, advanced age of the mother, and history of cesareans. It will present in mothers in their second or third trimesters with vaginal bleeding that is bright red with no feeling of pain.
Uterine ruptures occurs when the endometrium, myometrium, and perimetrium of the uterus split completely. It often results from high parity, trauma, past uterine surgery, patients with a previous history of C-sections, and women in labor experiencing severe uterine contractions. It will present with vaginal bleeding, abrupt intense stomach pain, loss of fetal station, and symptoms of shock in the mother. We investigate the management and treatment plan of this condition in the following section.
When paramedics attend to the pregnant patient in active labor, it's important to recognize there are potentially two patients. This will affect the allocation of resources,
place an extra demand of care to the attending team or responder, until careful planning and information extraction is required to ensure mother and baby receive optimal care and intervention.
Our assessment components such as doctors ABC, D, sample, OPQRST remain the same, for example, with the incorporation of Rita questions that are specific to the current pregnancy and history overall.
Baseline vitals should be obtained. Examination for any external visible trauma to the mother, palpation of abdomen, tenderness, rigidity, guarding masses, and other abnormalities. Auscultation can assess the mother's respiratory and cardiovascular function, as well as the baby's fetal heart tones.
Positioning in supplemental OXU should be selected to improve airway function, relieving distress and maximizing perfusion.
In preeclampsia, obstetric emergencies, any hypertensive conditions or events should be stabilized prior to proceeding with the delivery, such as coagulopathy, fluid expansion only in the event of severe hypovolemia or other avenues dependent on the level of complication.
High-infant hospital deliveries have been linked to an elevated perinatal mortality and morbidity risks for both the neonate and the mother.
Breech presentations are the most common type of malposition encountered and once active labor commences, it is out of anyone's control. The role of the paramedic is to ensure delivery is managed in a controlled way that provides directional prompting in the birthing maneuver for the infant through the birth canal, the management of postpartum bleeds, and basic care of the newborn.
Posturing of the mother in semi-phallus enables optimal ventilation and supports pushing efforts. Oxygen at high flow can assist in slowing the tachypnea from rapid respiratory efforts from contractions and pain.
Analgesia that can be offered includes Entonox to assist both with pain management and boost to perfusion and relief from respiratory distress. Paracetamol and morphine sulfate are also secondary options.
Uterine ruptures should be suspected with presenting maternal shock or inability to palpate the uterus.
Our assessment should look for uterine tenderness, non-reassurance,
localized abdominal pain, vaginal bleeding. This patient needs specialized surgery in a hospital setting.
The treatment rationale in a pre-hospital setting is to ensure stabilization on transport, managing any cervical injury and trauma. Any symptoms of shock should be managed with standard hypovolemia reversal protocols, oxygen therapy to maintain perfusion, and analgesia to maintain patient comfort.